I like the CT scan with contrast. I think I can interpret it very well, and I understand that compared to MRI. The whole body PET scan is also very important, and people like to do the MRI of the brain to make sure there is no metastatic disease. Again, very important to do the mutational analysis with BRAF. The minute the patient comes into us, our institution, we do a repeat needle biopsy. By the time you get the slides from outside, it may take forever. We do a needle biopsy, FNA, and send it for immediate BRAF analysis with the immunohistochemistry. And we can get the answers within 24 hours, so we can start treating the patients. The surgeon's role is also very critical to do a laryngoscopy and evaluate the extent of the disease and the airway situation, what is happening with the airway and the vocal cords. Now, I just want to show you this recommendation 20 and recommendation 21. Whenever we deal with aggressive thyroid cancer, the first thing is to find out if it is BRAF mutated. You can literally divide the anaplastic thyroid cancer like the oropharynx between HPV and non-HPV. The same here. Is it BRAF positive? Is it BRAF negative? Because the recommendation and the treatment choices are quite different and very efficient. If it is the BRAF positive patients, the survival has improved now from 3 months to average survival of 3 years or more. I just want to show you this example. This is a 60-year-old gentleman, had an open biopsy outside, which we will never do now, or rarely do it. You can see the tumor fungating through the skin, that there is a hematoma and a bloody leak. And you can see here, I just wanted to show you the CT scan, very extensive tumor, going right up to the innominate. You can see this is surgically incurable, you cannot resect this. And this is the needle biopsy. You can see here, this patient had an open biopsy outside, and these are the slides. You can see tumor necrosis and anaplastic thyroid cancer. So what did we do when the patient came to us? We started the patient on the BRAF related treatment, which is dabrafenib and trametinib. There was a mild elevation of the LFTs. Majority of the patients handled this very well. Obviously, you have to watch for the side effects and complications. Sometimes there is a stiffness of the knees, occasional cough, but nothing serious that we need to stop the treatment. We continued the treatment for 3 months, and I just want to show you, look at the CT scan pre-treatment and the post-treatment. Majority of the tumor has condensed or almost disappeared. I just want to show you another picture. You saw this picture before, and now there is hardly any tumor here. This is the ideal response to BRAF patients. And again, I think there is definitely a ray of hope and paradigm shift in management of anaplastic thyroid cancer. Subsequently, patient underwent total thyroidectomy and central compartment dissection. And what was interesting, we were able to preserve both the nerves, the parathyroid function was satisfactory, and the patient recovered from surgery very well. What is more interesting is, in this specimen, there was no residual anaplastic thyroid cancer. No necrotic tissue was seen. So this was the best result we saw in this patient. There was a small area of microcarcinoma. There were 3 positive nodes, most of which had papillary microcarcinoma. And this is the surgical pathology. You can see here, this is the residual papillary thyroid carcinoma. This patient did extremely well. You can see the surgical pathology here, and he's alive more than 3 years now. So this is clearly a definite advance in the management of anaplastic thyroid cancer. So what are the major surgical issues as a surgical group? Is it resectable? How do we do the airway management? Remember, nutritional support is very critical. The minute the patient walks in, you think, is he going to have trouble swallowing? And should I put the NG tube or do a gastrostomy now? Consideration of surgery after BRAF-directed treatment. There's always a debate after the excellent response with BRAF. Should we operate or should we just send the patient for radiation therapy? MD Anderson gets a lot of credit. Their surgeon Mark Zaverio did a fantastic job in operating on these patients, and we have been following the same routine. Surgery after the complete response. Obviously, the hospice and ethics are very important. I wrote a paper many years back about the airway management in anaplastic carcinoma. This was a personal experience. Every time we did tracheostomy, it was life-threatening in the operating room, number one. And number two, the tumor grew through the tracheostomy opening. The tumor grew around, it bled, and the patient's life was miserable. And we sat down and started thinking, are we helping the patients or hurting the patients? Yes, we prolong the life by a few weeks or maybe a month, but with suffering of the patient. This is a classical example of the tumor growing all around the tracheostomy. You can't put the tracheostomy tube. Majority of the patients will die of airway distress. This is one of the nice paper from MD Anderson, upon which I had an opportunity to write editorial. This is a large single institutional experience. Patients were treated with neoadjuvant treatment, that dabrafenib and trametinib. Interestingly, they also add immunotherapy with that, pembrolizumab. We have not tried that at Memorial, but I think there is always a future. And I'll show you some data from MD Anderson showing excellent results with dabrafenib, trametinib, and pembro. You can use neolimumab. It is a matter of your practice. Patients showing only residual papillary carcinoma did the best in this group. And this is a classical example. You can see here. The overall survival was very poor from 2000 to 2013. When they added the dabrafenib and trametinib, you can see the survival improved remarkably. Just wanted to show you the patients who underwent surgery after all this treatment, dabrafenib, trametinib, the BRAF-directed treatment, they did remarkably well. Take a look here at survival compared to those who did not undergo surgery. Also, it is very interesting to notice the BRAF patients did remarkably well compared to RAS mutation here. This is the RAS and this is the BRAF. There is something with anaplastic third cancer and BRAF mutation which gives the best results. And here is a classical example. You can see here this patient with very advanced anaplastic third cancer. You can see the carotid artery inside the tumor. With 1 year of dabrafenib and trametinib, you can see the excellent result here. The carotid has come out of the tumor. This is a classical publication from MD Anderson where they showed initially 6 patients with very advanced anaplastic third cancer who did remarkably well with the treatment that we proposed, dabrafenib and trametinib. You can see here within 3 to 5 months, majority of the patients responded extremely well. The patients who underwent surgery, if there is a residual anaplastic third cancer, they did not do as well compared to those who had residual papillary thyroid carcinoma. Again, I just wanted to show you the neoadjuvant targeted therapy. Now, from 2017, you can see here the remarkable progress. Those before who did not have surgery or did not have the BRAF-directed treatment did very poorly. At the end of 12 months, there was barely 25% survival. Now you can see here the survival goes up to 36 months. Remarkable progress. Clearly, with the immunotherapy, as I mentioned to you before, you can see here, this is again the data from MD Anderson. You can see here the survival is much better with immunotherapy as compared to those without immunotherapy. So what is the take-home message? The take-home message is BRAF status is very critical in this patient. Neoadjuvant targeted therapy is also very important. We also need to study a little more in details regarding the immunotherapy and its side effect. Is there a ray of light? Absolutely yes. I'm convinced that this is one disease where we have made a major progress in last few years. Unfortunately, in the non-BRAF positive patients, they don't do very well. This is the patient with the non-BRAF, you can see here. However, with the unresectable tumor, with the radiation therapy and chemotherapy, there is some response, not enough compared to BRAF positive patients. As I mentioned to you before, I had an opportunity to write an editorial on the paper from MD Anderson, and I titled it as Shifting Paradigms, a Ray of Hope. So what are the different basic philosophies of Ray of Hope? Number one, develop a multidisciplinary anaplastic thyroid cancer team. Rapid consultations, as I mentioned, the flurry of email goes, and we don't give appointment to these patients. They come to our clinic and we see them right away. Nobody will refuse to see them, our medical oncologists or our radiation therapists. Evaluation by all subspecialties concurrently. There is no one appointment, another appointment, the appointments go for a month. No. Surgical evaluation for a surgeon is very important about the airway. Confirmation of the diagnosis with repeat needle biopsy. Don't waste time. Appropriate imaging, which is a CT scan and a PET scan. Communication with the pathologist to do the BRAF studies within 24 hours. Targeted therapies, post-operative pathology is very important, and you need to talk to the pathologist, so when you send the specimen after second surgery, they need to know what is going on. And you develop your institutional protocol. Again, I want to repeat about the involvement of the ethics and the social service, and what are the patient and the family expectations. Keep in mind,